Good day, everyone. My name is Tammy Harper. I'm a nurse practitioner at Keck Medicine of USC in Southern California and Los Angeles. My specialty is transplant hepatology, but I do have a background of internal medicine for approximately 15 years or so before I hopped onto the dark side of liver transplant. Today, I'd like to talk to you a little bit about real-world practices with our patients who are on statins. As we know, MASH and MASLD has become an epidemic in this country, and I have the benefit of seeing this firsthand every day. I'd say in my own patient population, approximately 40% or so of my patients are getting transplanted for MASLD-related cirrhosis and MASH. And so personally, from my layover from internal medicine, I think that statins were the best thing since sliced bread because I had worked with them for so many years. But then when you look at a patient who's cirrhotic, who has compromised kidney function as well as liver function a lot of times, how realistic is it to use these drugs on a day-to-day basis? For my own personal practice, I rarely will stop a statin. Rarely. I can't remember the last time I felt compelled to do that in my pre-patient population. If there's an indication, i.e. they've had a coronary vascular events, they've been stented, MIs, strokes, those types of things, I may cut the dose in half. If they come to me on a high dose statin, I may cut the dose in half. Of course, always speaking with their cardiologist first before I do that. But normally I leave them alone. If they're become severely decompensated, what do I mean by that? Severe ascites requiring weekly paracentesis, thoracentesis, esophageal variceal hemorrhage. I may then once again take a look at the statin and possibly dose reduce at that time, always reaching out to their cardiologist. On the post-transplant side, because we know that my immunosuppression medications that these patients will be on lifelong do cause diabetes, hyperlipidemia, hypertension. Lots of times I am the person, if they're not seeing their PCP regularly, who will start them on a statin. And I feel very comfortable doing that. Obviously, my personal practice is to start the statin at a lower dose. And within a month, I'm getting labs. What labs? A CMP. And I'm also calling or having my nurse call the patient to make sure they're not having any myalgia, muscle pain, weakness, or anything like that. And so I hope this helps. Thank you once again for listening today. Please feel free to visit the MAP website for further information. Thank you.